Mr. Chairman, dear colleagues, it's my pleasure to talk about this topic. Actually, biliary injury was my thesis when I was a resident at Istanbul University under the supervision of Professor Erkan. And we were lucky enough to actually submit this paper to the, at that time, the European chapter of the E-AHPBA in 2001 in Amsterdam. And this was chosen to be one of the 4 excellent papers. And I was trembling because this was my first talk. And all the people who I used in the references were actually sitting in the first row asking questions. And I was really trembling at that time. Now, after so many years, I'm still interested in the topic, and I would like to see how actually the content of my talk has changed. The scope of the problem, as highlighted by also previous speakers, is big. The number of cholecystectomies performed in each country is not really representing their population. You can see that America is performing almost 10 times more cholecystectomies, although the population is not 10 times of England. And I couldn't come up with the numbers in Turkey, but you saw them also recently. It's a big problem. We used to believe that there was also a problem of a learning curve, which is actually not the case. If you look to these numbers, you will see that irrespective of the years, the left column shows years from 1992 to 2009, there are numbers which are actually more or less equal. Probably it's a factor dependent on the experience of the surgeon and the routine usage of devices and certain techniques at some centers. It's an unpublished data, but I had access to the German registry from Bavaria, and the registry says that actually the number is equal for open and laparoscopic cholecystectomy, and both lie around 0.5%. They will, I hope, publish this data soon. I will skip these data, but one thing new with the documentation of critical view of safety, we also changed our practice on when we perform laparoscopic cholecystectomy. With the recent data, in this randomized trial, now we changed our practice from cooling down an inflamed cholecystitis that didn't came to our hands within the first 72 hours. We still now forced to do cholecystectomy within 24 hours. On the contrary to what we have expected, this data actually shows that there is no increase in the frequency of bile duct injuries, but this has to be also confirmed by other centers. I'm not going to talk too much about the anatomical considerations or the mechanisms of injuries. I'm going to come now to the topic which I'm supposed to talk about, comparison of early versus late repair. When you read the literature in detail, you will actually find out that it is not an easy comparison because there are various definitions of early and the late. There are different classifications used by different authors, and the outcome measures are using also different classification systems. So I will try to summarize, despite these difficulties, in a brief way. Probably you are familiar with the Bismuth classification, but mostly it is used for strictures. Therefore, Strasberg extended this classification into strictures and also fistulas, and also sexual branches are also included in these things. There's also some Hanover classification, which is also quite reminiscent of the Strasberg classification, but I find it a little bit more complicated. It's not as widely used as Strasberg classification. And when you evaluate the outcome after biliary injury, 2 classification systems are most commonly used. One is by McDonald, quite also similar to what many of us who published in this area used. The criteria published by Schweitzer and colleagues, this was first published in the book of Blumgart, is actually taking into consideration the symptoms of the patient's biochemistry and also radiology. If you look to published data, you will see that successful outcome can be achieved between 75% to 95% of the cases. So there is a group of 5%, despite everything, that we actually cannot achieve really successful outcome. So one topic that might be relevant to this lack of success in many patients would be also the timing of the recognition of the injury. If you divide it into 3 categories, which is done mostly by the literature, you can detect it intraoperatively, you can detect it in the early postoperative phase, or you can detect it later. Intraoperative iatrogenic biliary injury detection is actually fostered, as the previous question was about, by the routine usage of intraoperative cholangiography. This is a recent paper from 2012, and they were showing that to determine whether the routine use of this technique can improve survival from complications related to bile duct injuries. They were making a population-based cohort study in Sweden. They were using multivariable analysis and Cox regression analysis, and they were analyzing all cholecystectomies performed between 2005 and 2010. What they detected was early detection during the index operation of bile duct injury increases survival, and routine intraoperative cholangiography usage reduces the risk of death after cholecystectomy by 62%. So not that every patient is, of course, dying, but I mean, if you use routine cholangiography, probably the scope of the injury is then smaller, and probably by earlier detection, people will get a better chance of treatment, I believe. It is nevertheless open for speculation. When you look into the details, among the 51,000 cholecystectomies, even in a country like Sweden, the biliary injury, when properly registered, was 1.5%. So there were 747 biliary injury patients detected during during this phase. 23% was detected during the primary operation, and the rest, approximately 3/4, were detected in the later periods. Among the 55 severe biliary injuries, approximately 3/4 again were detected during the first operation, but just remember that they are using routinely intraoperative cholangiography. There's another paper, a more recent one from United States, from New York actually state, comprising a 14-year period, again about the usage of intraoperative cholangiography. They were using ICD-9 codes to find out, and also laparoscopic cholecystectomy and bile duct injuries, how often these techniques were overlapping. And the study covers the period from 2000 to 2014. And what they were coming up was that the routine usage of intraoperative cholangiography was decreasing during this phase. But conversely, the number of biliary injuries in the cases where they used intraoperative cholangiography was increasing by an annual of 4% rate. So they were saying that the risk is increasing. People are not using that technique as often as they used to. And maybe it is because of the lack of experience. Maybe people are using it now more selectively for complicated cases. There is an inverse correlation between the usage of intraoperative cholangiography routinely and the frequency of biliary injury in this study from the United States from 2017. There's a new alternative published also recently in 2017 that some authors have used intraoperative ultrasonography to define the biliary anatomy, to look for injuries and to look for hidden stones. And this is covering a 16-year period, more or less the same timing. It is putting together 13 prospective non-randomized control trials, 5 retrospective trials, and 2 meta-analyses. And what they can tell is that routine usage of intraoperative ultrasonography is very sensitive for the delineation of the extrahepatic biliary anatomy. The portion they cannot really effectively delineate is the intrapancreatic portion of the distal bile duct. Unfortunately, inflammation, as expected, hampers also the diagnosis or proper interpretation of the biliary anatomy. Nevertheless, they were concluding that laparoscopic ultrasonography is advantageous to intraoperative cholangiography because of the ease of usage, but they are not mutually exclusive, and they were concluding that they can be even used together with a sensitivity of 96 and specificity of 100%. So there are some images where they can show the vascular structures by just switching on the Doppler effect, and also the merging of the biliary system, the cystic duct into the bile duct, and the merging of the right posterior sector duct into the common bile duct. So this is how it looks actually. I'm not going to also stay too long for the sake of time. Now when you look to the impact of timing on the outcome of repair, this paper published in 2012 came from France. It is actually a survey, 47 centers with 640 biliary injuries, 550 analyzed. They were comparing immediate repair with repair, early repair. This is, for example, an example of how early repair can be variant, less than 45 days, and late repair that is longer than or after 45 days. Approximately 1/3 of the cases were immediately repaired during the index operation, and when you look to the details, you will see that the majority of these repairs were actually suture repairs, so they were not going into complex types of repair when they were detecting this during the surgery. Maybe it is because of some tiny leak which they thought that they could suture, or maybe it is just an underestimation of the extent of the damage by the surgery. Biliodigestive anastomosis was only done in 19% of the cases. When you look what has been done in the early period, this is the first 45 days, suture repair goes down to half of the cases, and biliodigestive anastomosis increases again to the other half. And when you look what is happening in the remaining 25% of the cases, you will see that almost all of them have been repaired with some biliodigestive anastomosis. Many of these cases, especially the ones that were repaired in the immediate period, required a second repair attempt. So 56% required surgery after this initial repair. This ratio was also very high for my standards for the early repair, with 40% requiring a second operation, but only the 6.8% of the cases that were treated in the late after 45 days required a second repair attempt. So what they were concluding is also hepaticojejunostomy is a superior technique to suture repair. But of course you have to consider that hepaticojejunostomy in a non-dilated biliary system is also not too easy to perform. A similar study comparing long-term outcome after early repair of the iatrogenic biliary injury, again, some multi-center study from the Netherlands, from Denmark. This study covers a 15-year-old period, and all injuries sustained during cholecystectomy were repaired by hepaticojejunostomy in experienced centers. So this is now comparing something different. These are all hepaticojejunostomies done by experienced people in referral centers. You will see that success rate after early injury is lower actually than later repair attempts. The median interval between injury to repair was 5 days. Concomitant vascular injuries were approximately 20%. Morbidity, mortality are all within the normal ranges. Follow-up was 102 months, and hepaticojejunostomy stricture was 30%. So this is actually too high for what we were comparing or what we are used to read about repair by hepaticojejunostomy. And the factor is obviously not the experience of the surgeon, because these are all experienced surgeons who are performing these operations, but probably the timing of the intervention. So when you put these together, the French multi-center study and the Danish study, you will conclude that early repair is not probably easy to do. So biliary digestive anastomosis success obviously increases when the biliary system is dilated. So if you look to the recent E-AHPBA paper, timing of surgical repair impacts not on the patency, but on the complications is the conclusion of these papers. But you have to also look that these are a single institution prospective database only focusing on the E1 to E4 injuries by Strasberg classification. They are defining early within the first week, intermediate between the after first week to 6 weeks, and late after 6 weeks. The number of patients included is 614. Median follow-up is a little bit short. It is 14 months, and 95% almost were repaired by hepaticojejunostomy. I will pass these details, and I will come on the conclusions of the study. Remember that there were three groups, early, intermediate, and late. The intermediate repair was associated with a higher risk of postoperative complications. So there is no change in the patency of the anastomosis, but the complication rate increases in this intermediate period, probably because the bile is not too contaminated in the early period, and in the late period, probably you already know what kind of bacteria is there, because probably you already have some sort of PTCD and some bile sampling. And of course, in those cases, you can start right away with a therapeutic antibiotherapy. So when you put all these together, probably the take-home messages should be: timing has no significant impact on the patency on the bile duct anastomosis, according to the last paper published. But repair between these intermediate period has a negative impact because of the increased complications. But as I said, remember, these are all E1 to E4 biliary injuries, mostly in a dilated system. Again, some results from some high-volume center from Santi Banes's group. This is a single institution report covering a period of almost 2 decades. These are more than 10,000 cholecystectomies, and only 19 were injured in this institution during the 2-decade period. Intraoperative cholangiography was routinely used. 17 of these biliary injuries were detected during the index operation, and this is the classification. There were 3 type C, 12 type D, and 2 type E2 injuries. Just to remind you which classifications or which types of injuries these are, I'm showing you the classification of the Strasberg again. Sorry. Only 71% were converted to open surgery. The rest were repaired by laparoscopic attempt. 10 injuries were repaired by primary closure. 4 Roux-en-Y hepaticojejunostomies were performed, and 2 patients received an end-to-end anastomosis, and 1 patient was drained with some transpapillary stent. Mean follow-up was 71 months. Long-term was achieved in 88% of the cases. 2 patients were lost to follow-up in the 4th and the 5th years, and there were 2 unrelated deaths in the 2nd and the 12th years. Postoperative complications were 29%, and early biliary stricture was, again, even in this experienced hands, was like 11%. They are commenting also on the fact that there were no malpractice claims during the period. I'm now going to finish my talk with some estimation model. It's a Markov model. This is not a real scenario, but they are calculating what might happen if a biliary injury is repaired either early or late, or by the primary surgeon. In Markov models, there are Markov states. So these are constant, these are not changing, they are not following each other. So one situation is constant. So this situation is either death, liver transplantation, uneventful recovery, reoperative intervention, or interventional radiology endoscopy intervention. And then they check the literature and find out what the frequency of such situations are in biliary injuries. And then the rest is actually some mathematical algorithm. But this cost-effectiveness model demonstrates that early repair by a hepatobiliary surgeon is the best strategy for the treatment of bile duct injury in properly selected patients. Although there is little clinical difference between early and late repair, there is a great difference in the cost and quality of life because you are not draining a patient for some weeks, letting bacteria colonize the system, and then, of course, operating them once again in another round. So this is actually probably a nice way to summarize this incomparable data. So the take-home messages: if you are not an experienced biliary surgeon, if you are not familiar with biliary reconstruction, do not attempt to repair. Either ask for help or drain the patient and refer it to some HPB center. The problem is, of course, if you are an experienced biliary surgeon, you have to choose which case to repair during the index operation properly, perform hepatic jejunostomy when you can perform it safely. Sometimes it is really technically very challenging. If you think that this is not going to work out, also don't refrain from just putting a drain and waiting that the bile ducts dilate. If you are nevertheless going to perform a hepaticojejunostomy in such a case, explain the patient the stricture risks. So thank you very much for your attention.